working with her when she was Commissioner of Mental Health in Ohio. Not unlike Wayne, Pam has held about every job you can hold in mental health, and we're so fortunate that President Obama nominated her and the Senate confirmed her as the administrator for the Substance Abuse and Mental Health Services Administration. And Pam has been a stand for integration, recovery, and effectively structuring human service systems, certainly for the 24 years that I've known her and for her entire career. So having her in a leadership role is another extraordinary plus for us. And finally, Dr. Susan Angell heads the homelessness programs at the Department of Veterans Affairs. And as you know, the department has declared some very ambitious goals with regard to eliminating homelessness among our veteran population. And Susan's going to talk with us today about those initiatives and the audacious goal they have essentially of eliminating homelessness among veterans. So we'll start with Estelle and federal leadership in housing and urban development. Estelle?
Thank you, David. It's great to be here in Tulsa. It's been a long time since I've been here, and I'm very grateful for being invited. But what was really special, I got to attend the Habitat for Humanity dedication this morning, and it was so special. It just makes sure you continue to have in the pit of your stomach the understanding of why we all do this, to see a family receive the keys to a new home and to be able to own that home was just a great way to start this conference. And a special thanks to the Zarrow Foundations for making so much of this happen, and a double thanks to all the volunteers who I understand were out there in some pretty hot weather to be able to make this home come true. I also want to take a second to acknowledge my partner at the VA, Susan Angell, who, along with one of my colleagues at Mark Johnson, was recently honored by the Partnership for Public Service for her work that basically was between the VA and HUD. The partnership between the VA and HUD has been phenomenal and has essentially resulted in a 12% decrease in veterans' homelessness for the past year. So. Before I talk a few more about the future at HUD, I want to recognize the importance of partnerships at the federal level. Our departments do not just talk. We're actually true partners. We do things together. We talk a lot. We meet a lot. And the key really has been all of our leadership. Secretary Shinnecki of the Department of Veteran Affairs, Secretary Sebelius at Health and Human Services, and Secretary Donovan believe that working together, we actually accomplish more, our dollars go further, and we get better care. We not only all talk the talk, but we walk the walk. And I think that the key for all of us as we move to the future is to continuing to look at ways that we can indeed foster not only the partnership at our level, but also begin to foster partnerships at all of our community levels. The three things in the future of HUD that I really want to spend only a second talking about are our efforts to eliminate homelessness by 2015 for our veteran population and our chronic population, our initiatives into permanent supported housing, and our activities involving with the Olmstead decision. All of these, it was good to see, are being addressed further in different workshops throughout the next 2 days. So I certainly encourage you to look up some of those workshops and to get more depth in all of these situations. Eliminating homelessness. It has been an administrative initiative from the beginning. All of us here, plus 16 of our other partners, there are 19 partners altogether, along with the United States Interagency Council on Homelessness, continue to work on eliminating veteran and chronic homelessness by 2015. We also have a goal of eliminating family homelessness and all other ranges of homelessness by 2020. But every time I go to a meeting, we are reminded that 2015 is just around the corner, and what are we going to do to be able to actually make this real, not theoretical, not philosophical, but how are we truly going to eliminate homelessness? And the key is that we're going to do it together. Together is a incredibly operative word for us, and we are looking for ways to work with each and every community to make sure that not only can we provide housing, but we're in reality providing a home for people with any level of disability, including behavioral health challenges, who have been without stable, affordable housing for a long time. So our first look was to our public housing authorities, who are 3,000 of them across the country, who are our partners. And one of the things we have done is to try to make sure they understand that we are supporting local, not only local mission preferences for people with disabilities, which have been on the books for a long time, but we are urging them now to consider more targeted preferences for persons with disabilities who are homeless and for people leaving institutions. This targeted preference actually begins to get people to the top of the list, begins to say that we're very serious about having our housing vouchers and our standard housing look at these groups as a true priority. We're also encouraging them to re-examine any policies they have that preclude people with criminal backgrounds from entering housing. We understand that there's some occasions when that needs to be relevant, but we believe that people can look at their policies and begin to work with their communities by not precluding people just because they have a criminal background, and they need to take a deeper, more serious look. And we're asking them to work more intensely with their local partners, particularly the veterans, the VA, and their partners in Health and Human Services, both behavioral health and physical health. We realize that these are really tough economic times and that people have had tough ways to put all the funding together, but we really believe that if we work together, if we look for supports, we look at targeting our preferences, that we can eliminate homelessness by 2015. My second focus is on integrated supportive housing. We really are heading towards a world where not only housing is integrated, which is a critical part of where we're going, but we want permanent housing, and we want permanent housing which provides supportive services to assist people with a disability as long as they wish them, for as long as they want them in the way they're being offered. Our best example right now of integrated supported housing is our own new 811 Project Rental Assistance Demonstration Program. I have to tell you that we have a shock. We thought when we put this NOVA out on the street that we would get about 10 responses, and we thought that would be pretty good. We probably have enough money for somewhere between 8 and 12, so we thought 10 responses would be a pretty good idea. Anybody have an idea of how many responses we have? We got 35 plus the District of Columbia. The number that came in was absolutely overwhelming, which told us that every state, most this mandate and how to indeed work as a full partner with states, with their health and human services partners, with community organizations to make sure that after 13 years, Olmsted becomes a reality for each of our folks living in the community, not a philosophical bent. As HUD continues to be a program, our housing programs continue to be a support. We should be at the table. We want to be at the table, and we want to make sure all of our resources are there with us. Thank you so much for allowing me to be here and to work with you.
You want to say anything else?
Go ahead.
It's always great to be on the stage with Estelle. She and I have known each other for probably 30 years.
A long time.
And I'm very pleased to meet Susan. We've worked on many of the same issues, and it's a great partner in the Veterans Administration that we're doing lots of work with. So you're going to hear some common themes here today, and I want to also thank David and Mike and everybody else who has helped put on this conference. It's great to be here with you in Tulsa. SAMHSA, which is the agency I head up, is a public health agency. It works toward creating a nation of communities free of substance abuse and mental illness. SAMHSA's #1 goal is prevention, and the #1 goal of treatment is recovery. Those are no small statements. Those are major changes for SAMHSA and major changes in the philosophy about the way we look at the role and goal of the things that we pay for. Recovery, we have defined recently as a personal journey. It's built on hope, it's individually directed, and it's a process of self-determined wellness and quality of life. Now, you might imagine there are a lot of people who didn't particularly like that definition of recovery, but we thought we needed to get to the basics. And we have 4 domains in recovery. One of them is health, one of them is home, one of them is purpose, and one is community. These are interrelated domains, and none is possible without the other, and recovery is not possible without all 4. A person's health, purpose, and community are all greatly jeopardized when housing is dangerous, substandard, not affordable, or just lacking completely. A home requires obtaining and maintaining safe, stable, affordable housing. Housing is often lost or jeopardized by addiction and mental illness. Treatment for these conditions is critical and necessary, but frankly not sufficient. Supportive services to support recovery and to support housing are often necessary to maintain housing, to build a home, to secure a purpose and a supportive community, and to support recovery. Stable housing offers safety and hope. Both are essential for recovery, and frankly, safety from lost hope is just as much a public health issue as safety from bad drinking water or infectious diseases or the nightmares and flashbacks of combat.
You're here.
Now let me do just a quick set of numbers, things that you already know, but just to set the stage here a little bit. Of the people who are chronically homeless in our country, at least 30% have a serious mental illness and 60% have a substance use disorder, and there are other people who have more minor mental illnesses. Among sheltered homeless adults, about 1/3 of them have substance use disorders, about 1/4 of them have a serious mental illness, and almost half have co-occurring disorders. Of people receiving using homeless residential services, about 6.4% reported either a psychiatric hospital, a substance abuse treatment facility, or a hospital as their living arrangements the night before they went into a homeless shelter. Of the 1.8 million treatment admissions for people over the age of 12, almost 13% of them were homeless at the time of admission. And in 2009, mental and substance use disorders were the single largest cause of hospitalization among U.S. troops, more than any other cause. People in jails and prisons, as you know, have highly disproportionate rates of mental illness and substance abuse. Veterans represent an unacceptably high proportion of persons in jails and prisons, and people who are chronically homeless as well. But this is changing, and the Obama administration has made a commitment from the VA to HHS to DOL to Department of Labor to HUD to eliminate the connection between the word veteran and homeless, and you're going to hear more about that in a minute. Frankly, in America, I don't think the word homeless should even have to exist.
Hear, hear.
I think you all know that homelessness are associated with all kinds of lack of health care, lack of substance abuse care, exposure to trauma, increased mortality, and all kinds of bad health outcomes. The point here is there's a major connection between substance abuse and mental illness and homelessness. We cannot deal with homelessness without dealing with substance abuse and mental illness, and yet we can't just provide a service and expect that that's going to fix housing. Now, I've been in health and behavioral health and human services for almost 35 years, and I've lived through the times when, frankly, behavioral health systems thought that services and treatment was enough. Somehow, magically, if we could manage the hallucinations or we could manage the substance use, then housing would sort of magically take care of itself. I've lived through times when the behavioral health system thought that it should provide treatment settings but not housing, and that a referral to a housing provider by itself was sufficient. I've lived through times when we wanted to provide residential treatment but not housing, when we wanted to provide transitional housing but not permanent housing, and when we wanted to own the housing ourselves. I think I've been around too long. I've actually also lived through the times when we thought specific models were the panacea. So where we thought segregated protective housing was the way to go, such as group homes or halfway houses, or where we thought independent scattered site models was right for everybody, or sober living models was appropriate for everybody, or therapeutic communities was appropriate for everybody, or separate housing for veterans or people with disabilities or people in recovery, or you name it. We thought that was right for everybody, or we thought that housing with independent apartments in a common building with on-site services so staff could help everybody, we thought that was the right model. I think we frankly now understand that different people at different times in their lives and in different circumstances need and want different things. Integrated. I personally am living in transitional housing at the moment. Transitional between my home in Santa Fe and my life in DC for as long as it's there. Integrated and supportive housing, the terms that Estelle was living, can be done with lots of different models. And I think it's time that we stepped back and said recovery really is self-directed, and it really is about what the individual needs for themselves. So we now understand that clinical and treatment services are usually necessary but not sufficient, that housing and home is a necessary condition for recovery and treatment effectiveness, not the other way around, and that we as a behavioral health system cannot do it alone, as Estelle said, nor can we expect our partners to do it without us. We need the payers of treatment services, the providers of human services, the payers and providers of support services, community-based natural supports and natural supporters, housing providers and authorities, and frankly, we need our defense, veteran, disability, civil rights, children and family system partners. A number of states have already begun to expand and look at Medicaid eligibility and explore ways to use Medicaid to secure services for people living in supportive housing. But they're only going to pay for certain things. They can pay for a lot more than we have expected them to pay in the past. However, making sure that rent is paid on time, building relationships with landlords and neighbors, helping to monitor medications, reducing alcohol use or managing symptoms, keeping a clean apartment, some of those things will be paid for by insurance-based approaches to clinical treatment. Others will not. So we need to make sure that we address the challenge of how these services flow through many different agencies and payers and organizations, both governmental, public, and private nonprofits. These and other human services like food, like childcare, legal services, transportation, accessing veterans and benefits, they have to be a package to support a person's life and recovery. And they're all paid for differently. You have to lobby them differently. You have to advocate differently. And you have to put them together in a package. So the puzzle of matching eligible clients and eligible providers and eligible services is exceedingly complex, and we have an added challenge today while state and local fiscal constraints are further complicating the problem. So I just want to do 2 more seconds here on SAMHSA and what we're trying to do with the services that we provide. We do lots of things, from providing materials like our evidence-based practice toolkit on permanent supporting housing. We also have rethought our grant-making process. So we had several different homeless technical assistance centers that we have tried to consolidate into one. We have many different grant programs that we have tried to braid the funding for, so that when somebody comes into a provider or into a agency that has one of our grants, they don't have to worry so much about, does the person have substance abuse or does the person have mental illness? We can serve them in either way. We have done exactly as Estelle talked about from their point of view. We have put into our grant requirements that they must look at mainstream programs, and they must partner with Medicaid and have them at the table, and they must have housing authorities at the table. So we are trying to practice this issue of partnership in many different ways. SAMHSA has about $139 million in grant programs, and we're focusing on certain things. But first and foremost, we just shifted from saying, it's not that we don't want to provide services. We do want to provide services to people who have substance abuse issues or mental illness and are homeless, but providing services to them and leaving them homeless is not acceptable. So the goal of these programs is now housing. So in the first 6 months of this new approach, we placed over 300 individuals into housing, with that being the assumption that our services should work to do that. The funding sources to help do that include everything from HUD to supportive housing programs to project-based vouchers, Shelter Plus Care, Section 8 vouchers, veterans programs, public and private program partnerships, and local housing authorities. So we've really tried to partner with them. We have a community living initiative that includes some work on Olmsted. As Estelle said, we have an Olmsted Policy Academy with 5 states coming up that is a partnership among all of us. And it combines efforts from HUD, from CMS or Medicaid and SAMHSA. It also encourages public housing authorities and agencies to establish people transitioning from institutions as a priority population, as you heard. We also have a chronic homelessness policy academy coming up in 2013 for the 6 states that have the highest proportion of chronically homeless individuals in their states. The idea will be to use web technology and another number of other approaches to help those states really plan for reducing those numbers. Again, this is a partnership between HRSA, HUD, the Veterans Administration, CMS, or Medicaid and ASPE, which is one of our partner agencies in HHS. So the bottom line for SAMHSA is something that many of you have heard me talk about, or us talk about a lot, and that is that behavioral health is essential to health. You can't have health without good behavioral health. Prevention works, treatment's effective, and people do recover if they have health, home, community, and purpose. So our goal is people's lives. That's not the services, not the programs, not some rigid model, but it's their lives. These are the means to an end, and safe, healthy, supportive communities and people are what we want to see. Thank you very much for having me today.
I'd like to start with 2 quotes. In March of 2009, President Obama said, "We will provide new help for homeless veterans because those heroes have a home. It's the country they serve, the United States of America." Secretary Shinseki said, "Those who have served this nation as veterans should never find themselves on the streets, living without care and without hope." And with that, he really turned our organization upside down in terms of how we looked at ending homelessness for our veterans. He said he wanted it done by 2015, and I can assure you we are all marching to those marching orders. We went from an organization that did a pretty good job of rescuing, did a pretty good job of referring to transitional housing and shelters, but honestly, our homeless veteran population was growing every year. The thing that I think we learned from HUD and from our community partners that is that if you're going to end homelessness, you have to have a home. So I think that's where we learned that and have really turned all of our efforts in that direction with the goal of a home, not always treatment first, but the goal of a home. Today I'm going to highlight 3 aspects of that. The first will be outreach. The second will be our newest program, Supportive Services for Veterans and Their Families. And the third, I want to talk about HUD VASH, because I think that's where we've learned some tremendous lessons. So I'd like to have the video cued at this point.
Sergeant Michelle Garcia served meritoriously in Iraq and has the medals to prove it. Soon after leaving the Navy, Lieutenant Chris Scott found a job, a home, and started a family of his own. Corpsman Richard Stokely took the skills he learned in Vietnam and put them to good use as a paramedic. But soon after leaving the military, each of these veterans fell on hard times and faced homelessness. Even after Michelle lost all her savings, even after Chris wasn't able to pay his mortgage, and even after Richard battled alcoholism for years, they each reached out for help when they needed it most. A simple phone call put them in touch with a trained professional from the Department of Veterans Affairs. That call got Michelle a place to stay until she could afford one of her own, put Chris in touch with employment assistance, and found Richard a substance abuse program. These veterans are success stories not only for how they were able to help others while serving their country, but for how they were able to let others help them. If you know of or are a veteran in need, make the call.
This is a PSA that will start showing up in your communities. What we wanted to do with this, not only is it a reach out to our veterans and their families, but it's really a call to action for community members, for providers, for friends of veterans, for any American who really wants to help a veteran, knows a veteran who's in need, and can use this number. We can go to the next slide, or I guess I have the clicker here. The National Call Center is staffed 24/7 by professionals, and their goal is to, for every single call that comes in, that they will match that person up in their community with whomever can help them. So if this is a veteran who calls, we'll get them hooked up with the medical center. If it's a provider who calls, we'll get them the service that they're asking for. We went across the country with our leadership, 28 cities in 2 weeks, and really the campaign was Make the Call. That was one of the biggest outreach efforts we've had in terms of ending homelessness for our veterans, to really start that process of letting folks know there are services available. It's been amazing to me in my career of 30 years in the VA, how many of our veterans don't understand the services that they've earned through their service to our country. So this is a really good starting place, and I want to just show you some data, just that 2 weeks, and the beginning of this outreach with this PSA, the kinds of difference it's made to our call center. So if you look over on the far left, the green line is this last year. That's the number of calls that went to the call center, and you can see the spikes as they relate to Make the Call and the call to action across the country. We were able to increase the number of calls to our call center by 200%, which is quite amazing because that represents veterans, their families, their friends, and community providers. So we're pretty happy about that. We've also jumped into the 21st century, or our secretary pushed us into the 21st century. We now have chat lines. We can do lots of things online. And again, the Make the Call campaign and our outreach efforts have really made quite a difference. I want to go next to supportive services for veterans and our families. This is one of the most exciting programs we have, and the very newest program we have. This is a program that was lessons learned from HUD with their HPRP dollars, where they were able to prevent homelessness and rapidly rehouse folks across the nation. We took the lessons learned from them and we turned it into our supportive services for veterans and their families. What's unique and exciting for us is this is the first program that we have where we can actually include the family of our veteran. A barrier that we had in serving veterans who were homeless is that oftentimes they had families and they were not eligible for any kind of care or service from us, so of course they didn't reach out to us, but they did reach out to their communities. So with supportive services for veterans and their families, as of this summer, we'll have put out $100 million, all to community providers to help our veterans and their families. What's exciting about it, the money can be used for prevention, the money can be used for rapid rehousing, the money can be used in a way that makes sense for the veteran, the individual veteran and their family. We're pretty good at developing a broad range of programs that are a little bit cookie cutter, or maybe a lot cookie cutter. And in the past, we kind of expected our veterans to fit into the cookie, if you will. But in this program, it's what does this veteran need? Maybe this veteran only needs a deposit to get into their next residence. Maybe this veteran only needs a rent subsidy for a few months. Maybe they need child care. Maybe this person is ready to lose their job because their car is broken and they don't have the money to fix it. We can help them with that through our community providers. So we have 151 across the nation, 49 states. The District of Columbia and Puerto Rico are all participants in this. We expect that we are going to be able to expand this threefold. Although we have the 100 million out now, we really want to ramp this up to 300 million because we think this is one of the best programs we're going to have to really end veteran homelessness and include the family in that process. Our first clients we saw in last October, and our goal was to serve 24,000 in the year, and we've already hit 28,000, and we're very proud that of that, 6,000 of them are children. So we're very, very excited about that. The last program I want to talk about is the HUD VASH program, and once again, HUD is our very, very best partner. They've taught us a lot. We work together. We figure out how we're going to fix issues that we have. Like Estelle said, we actually descend on communities that are struggling. We have creative interventions, and oftentimes we see great improvements after we've descended, probably not from our intervention, but just hoping we don't come back as a team again.
Right. Unfortunately, that's probably good.
Because we're intense. When you get Estelle and me and Mark Johnston and several of our teammates in a community, it can be pretty intense. But what we like about this program, we do not have the authority to provide money for permanent housing. That is in HUD's lane. So HUD will provide the money for vouchers to the Public Housing Authority, and we provide the intensive case management services. What I think this process also brings to the fore, whenever you have a program, whenever you're serving a population, it's not all about a big heart and good ideas. You really have to look at the data and see if you're doing what you said you were going to do. So we rigorously individually look at our data, individually look at our performance, and then twice a year we meet with our respective secretaries, and we have to tell them how we're doing, the good, bad, and ugly. And it's really, you can't imagine for two federal agencies to come together and really put out transparent data with each other and have the trust that you're only going to work towards fixing issues and there's not going to be a lot of finger pointing. We have a no blame meeting, and it's really quite a powerful meeting that we're taking part in. I really believe that the 12% reduction that we were able to realize between 2010 and 2011 point-in-time counts is a result of that teamwork. The partner that we also are very, very dependent on are our community providers. Our secretary considers our community providers the creative geniuses who are also showing us the way. An example of that is Housing First. The community got there before we did, well before we did. In VA, we were kind of scared of Housing First because really people should, deal with their substance abuse. They should get their mental health issues fixed first. And then once they do that, we'll think about getting them in a home. But we realize communities have actually gone forward and said, when you have someone who's vulnerable and you get them a home, their capability to heal and move on and take part in productive treatment is greatly increased, as evidenced by their ability to stay home and stay much healthier. So we're learning that lesson. For those of you that work with your VA, please be patient with us. We're kind of a very careful workforce, but we're getting there with the push of our secretary and really the support of our federal agencies and our community providers. I want to summarize how we started this journey and how we're moving forward. Whenever you're in a very large agency, where you go is pretty dependent on your leadership, and we could not have a better advocate in our president and in our secretary Shinseki in moving the needle on ending homelessness for veterans. So he set the goal. He said that everybody in VA will be involved in terms of leadership engagement, and my job is to go around and involve my colleagues who probably have never been so involved in their entire life. But so far, I'm pleased to say there isn't a leader in VA that has said no to me. So I go around with the glue gun. But you have to have a plan. You have to have a foundation, and our foundation is based on 6 pillars: prevention, outreach, treatment, housing, employment, benefits and income, and last but not least, but critically important, are the collaborations that we have with our community providers and our 19 federal partners that Estelle made reference to. Once you've got your foundation, you've got your partnerships, you have to be data-driven in how you decide to use your resources, and you have to look at the data constantly and continuously so that you can pick up trends that are working and you can stop doing things that don't work any longer. So for me, it's been an honor to work on this program and to have a secretary who is so motivated to see not one veteran left behind on the streets. And we hope with your support and with the support of our federal agencies, at the end of 2015, we'll have achieved that goal.
That was a great panel, and there are a couple themes I think that emerged, at least for me. One was there we go. I was wondering if and when I was going to come on. That one size doesn't fit all, in a way. Pam, you really sort of emphasized that. I really appreciated you kind of running through the history of the last 30 years of the various approaches that we've taken, and that people have different needs. I know when we were preparing for this, Susan, you were talking about, because Estelle's talking about the integrated supported housing, permanent housing in the community, not more than 20% of people having a disability in a particular housing development. And some of the stuff that you were talking about, Susan, when we were preparing, was that some veterans actually prefer to be with their community. So one size doesn't fit all, and we need a variety of models. Another theme that I think emerged, which was interesting, and sort of in your comments about innovation coming from the community. You know, there are people, a colleague of ours, Joe Morrissey, used to say that in our field, innovation really comes from the community, less so from the sort of the laboratory in a sense. And our job is to sort of grasp and understand what that innovation is and try to sort of codify it and disseminate it. So I was curious, and the other thing that they picked up on is what appears to me, and I appreciate your observation, as kind of a new day in terms of federal partnerships. And I know after the President's Commission, there was a. Okay, good. So I can do like a more, for those of you who are my age range, you can more Phil Donahue. Do you remember Phil Donahue? It's not on yet. How about now? Hold it close. Oh. Did you ever want to be a rock star? That's what appears to be kind of a new age of federal cooperation, it seems to me. And I was thinking after the President's Commission, you know, several of these interagency work groups were established, and it seems like with the current leadership that they have continued to be emphasized. When you think about some of those things, Estelle, and when you talk about permanent supported housing and the necessity of that support coming from other parts of the government, what do you see sort of as the bright spots, and what are things that are concerns to you about actually having this be a sustainable initiative? Now, try your mic. I don't know.
Can you hear me?
Yeah.
Okay. You know, first, I think the partnerships are exciting. We are, you know, I talk with the folks at HHS every week. We have an hour, half-hour call, sometimes goes a little longer, but talking about all the issues that come up. On permanent supported housing, probably the most exciting was our new 811 program, where both Medicaid directors and housing folks had to come together to present a proposal back to HUD. Again, we really thought the group wouldn't necessarily come together, so the fact that 35 states were able to do this and to get an agreement not only was exciting, but means that partnerships work. And the partnerships do need to work at the state. And HUD and HHS are very different agencies. HHS, for the most part, works with states. HUD doesn't work with states. HUD, for the most part, works with providers, developers, housing authorities at the ground. This took a while, but I think we learned a lot about each other so that as we go into the future, our relationship with VA and with education are somewhat different. We hold ourselves accountable to numbers. We do something called HUD Stat. For anybody who's been involved with ComStat type programs, we come together about every quarter to look at how we've made progress. And if we haven't made that progress, we look at how we're going to change what we're doing. So it's a very dynamic process. It holds our feet to the fire on a pretty constant basis and continues to have us look at what's working and what's not working. In a partnership, I think, as Susan said, we all have to leave the egos at the door. We all have to figure out that things said aren't about us. Things said are about how do we get better and how do we problem solve. I think all of our members, all of the members of the Interagency Council on Homelessness, led by the President, are very clear of his expectation that we will find a way to work together. We will find a way to problem solve, and we will find a way to hold ourselves accountable for outcomes.
It's interesting. So the importance of leadership, as well as kind of the history of developing these relationships. And it's nice that you were so pleasantly surprised that state Medicaid authorities came together with the housing authorities
Yes.
to apply for those grants, because you're right, it's just the kind of crazy way we have our government structured in many ways that makes a difference. And so, Pam, the good news is that we anticipate that Medicaid will be expanded in the Affordable Care Act, and more people who might not have traditionally been eligible, Estelle, because I mean, it's part of the issue is sort of working poor, and the people who wouldn't have been recipients of those benefits will have the kind of support, perhaps partially provided through Medicaid, so that they can stay in their housing. As you think about sort of SAMHSA's evolving role in a post-healthcare reform environment, how do you see the sort of the national leadership role of SAMHSA changing in response to that, and with particular emphasis perhaps on sort of filling the holes in the safety net in terms of the kinds of flexible services that people often need to remain in housing?
That's a big question. I think what you're going to hear from all of us, and you did a great job talking about Secretary Shinseki, and I could talk about Secretary Sebelius, you could talk about Secretary Donovan. I think all of us are incredibly big fans of the people we work for, because it's literally Secretary Donovan and Secretary Sebelius who said, we want to do this work together. It's literally Secretary Shinseki and Secretary Donovan who said, we want to have a goal. I mean, and Secretary Sebelius is actually chairing the committee that Estelle talked about, that all three of us are on, plus the Department of Labor and a couple of others. So there is this expectation of collaboration. And I started that way because Secretary Sebelius was a governor. And so when she came in, she said, I want Medicaid to change from being a unhelpful, difficult, guess what I'm thinking kind of agency, to being an agency that says, how can I help you? And the number, now, you can read the headlines and you can see all the back and forth politics of stuff going on, but inside, when we're working with the states, it's amazing how many states are saying, actually, Medicaid's actually helping. Medicaid's actually trying to help us figure out how to do this. So it is less of a stretch for us to put something in our RFAs, or for Estelle to put something in her approaches that says, we want this to be who you bring to the table. Again, the point of that, in terms of SAMHSA's role in what you were asking, we actually have great partnerships that frankly predated this administration, so I don't want to not acknowledge that. But for example, the Veterans Hotline and our hotline is one and the same for suicide prevention, in the sense that you can call one number and you can either go into the general group, or you can push one if you want to say you're a veteran or a person of military personnel, and it'll go right into a specialty line for veterans and people in the military. So we have, I mean, that's an incredible partnership that has been just terrific. And if you hear either of us talk about it, they'll talk about that. So SAMHSA's tried to move away from thinking that we could do it all, and stop thinking about ourselves as a sort of a box that we're in, and being very clear that we're actually a fairly small agency. And while we have a primary voice about behavioral health issues, we don't know everything about veterans. And while we have a primary voice about housing supports, we sure don't know about housing per se. And that we have something to offer to every one of these efforts. We're actually just doing a relationship with the Veterans Administration around, I'm going to get technical here on you, a data segmentation project to see whether or not we can actually create electronic records with the VA that will move information back and forth in a health environment and still protect substance abuse data. So we're doing all kinds of things in which SAMHSA is trying to be a partner that has a specialty and a special voice and a special set of expertise, but we are not the be-all and end-all. I think our biggest issue is we have block grants, and every one of our states get block grants, our block grants. Unfortunately, those are changing big time. They serve about 8 million people, but there's more like 11 million people waiting in the lines, waiting in the background to come in to coverage in 2014. And so we're going to start having coordination of benefits issues we've never had before. We're going to start having one person who gets their services partly in Medicaid, partly in the block grant, and partly somewhere else. So we've got a much more complex system coming on, and we're trying to do a lot of planning and work on that. And at the same time, trying to establish what I said a little bit about SAMHSA's role as a public health agency. We're not just a grant-making agency. We do a lot of that. But we are really about the behavioral health is essential to health, and you can't have a healthy community, you can't have a healthy America without good behavioral health.
Boy, I couldn't concur more, and I really like the public health metaphor and being as fundamental as safe food, clean water, et cetera, et cetera. And I think that's part of the transformation we need to try to engineer so that people come to understand that. And Susan, it sort of leads up to maybe a little bit of a historical perspective from the Department of Veterans Affairs. You know, I think we've come to realize, obviously every day we see headlines about the challenges that are confronted by some returning veterans. It's important we realize it's not everybody. So being a veteran isn't like a condition, right? But some...
It's an asset.
Exactly. How has thinking at the VA changed over the last few years that you've been there in terms of the sort of the centrality or importance of behavioral health issues in this broader context of really supporting people in their goals? It seems to me that that's really over the last several years, given the problems that we've seen. Certainly, we've become very focused on behavioral health issues. But how have things changed over the last several years at the VA?
I think that the trend that I see is certainly mental health has been a huge part of what we do and what we offer. But we've really gone from a model of disease and illness to a model of health, recovery, and quality of life. So it has a very individualized perspective. Again, it's not the cookie cutter. It's taking each veteran and their family. Where are they? What do they need? How can we help and not interfere? How can we be additive and not restrictive? So I think we've worked very hard with that. But the other part of that is, and I'll just reflect my first meeting with the Interagency Council on Homelessness, where the secretaries all convened. I was so surprised and really grateful. It really talked to how the American people want to serve our veterans. In the VA, it's like our veterans are ours. They're ours. We take care of them. We know all about them. Nobody can do it as well as we do. You know, we're pretty sure of that. And yet there are things we absolutely can't do. So, for example, when Secretary LaHood says, "I am making a commitment to hire, you know, X% of the next group of people that I hire, they are going to be veterans. We owe them a job." And then he comes out with one of our big blocks to housing and treatment. We can't provide transportation. So he's put grants across the country that provides transportation to veterans and their families to get where they need to go. So we have all these agencies saying, and here's what we can do. Eric Holder says, you can't get that information in jails and prisons for your justice outreach people, I'll get it for you. So everybody's coming together, realizing how critically important our veterans are, and that everybody has a way to serve our veterans as they served us. So I think, to me, that's the trend. We're opening up and having those partnerships in a real way, and can see the difference in the amount of care and services that are available.
That's a terrific way to kind of summarize a lot of the themes that we're thinking about. It's really thinking about a person's life in his or her context and their family. And Estelle, how you can craft strategies that help support people in that. But it's a lot more, Pam, like you said, than just providing treatment, although treatment is very important. It's not you can't use the sort of the infectious disease metaphor. You just get that penicillin shot and everything will be fine. It's that plus the kind of environment around which an individual is surrounded that can support him or her in that. So I think that it's been a terrific panel in terms of, I mean, clearly the cross-communication, the collaboration, the real focus on the person, trying to craft strategies for the person. The notion that I love the 4 points, Pamela, I probably couldn't repeat them off the top of my head about purpose.
Health, home, community, purpose.
There you go. That really gets to it. So let's thank everybody for flying all the way from Washington, D.C. having to change planes. And what we'd like to do now is to direct your attention, turn around and look at the bell. And I want to tell you a little bit about the bell for those of you who may not know about it. This is the symbol of Mental Health America and the mental health movement in the United States. That bell was cast from the shackles and chains that were used to restrain people in psychiatric treatment centers during the more barbaric periods of our treatment history. And it's been transformed into this extraordinary symbol of hope. And when you hear it ring with its clear tone, it's very evocative of the possibilities that we realize now for everyone, including people who have mental illnesses and addiction disorders. It is our tradition to open our meeting by ringing the bell and to close our meeting by ringing the bell. So gentlemen, if you would please formally open the meeting. Thank you all.
Thank you.
Is that it? Roll walkout music, roll walkout music.
You're off, we're off. Good job.
Okay, I had to unplug every single wire.